Now we're starting about the thyroid gland, and before we discuss about the disorders of thyroid gland, we should know about the thyroid percentage. The measurement of the T4, T3, TSH, and radioactive uptake, and how to measurement of the T4 thyrogline. It is the 5-fold less active than T3. Normal serum rate is about 4.5 to 12 microgram per kg. T4 levels are decreased in hypothyroidism of any organ. 85% of T3 are found inside the chemical conversion of the T4. Normal serum value is 115 to 120 nanogram per dl. This is less useful for diagnosis of hypothyroidism as compared to before. The measurement of the TSH, normal serum value is about 0.5 to 5 microunits per ml. The negative feedback relationship with T3 and T4. The most useful indicator for hyperthyroidism is hypothyroidism. Hypothyroidism elevated TSH but decreased T3 and T4. Hyperthyroidism decreased TSH but elevated T3 and T4. It means that the higher the ratio of T3 and T4, it means that we have decreased TSH but hyperthyroidism. The radioactive I2 uptake, it is the valuable in determining the etiology of thyroid disorder. It permits the function classification of nodules, which are the heart nodules. There are areas of increased uptake. For example, some are the jugular, goiteric, and vein and reflux. Now it is the cold nodules. These are areas of decreased uptake. The hot nodules were the areas of increased uptake. Now it is the cold nodules, decreased uptake. For example, arthritis and malignant reflux. Radioactive I2 uptake may be the increased uptake in whole gland, usually with Graves' disease. If it is increased uptake in solitary nodule, only nodule, then the toxic adenoma. If it is the decreased uptake in thyroiditis. Now some start about the hyperthyroidism and thyrotoxicosis. What is the difference between the hyperthyroidism and thyrotoxicosis? Now you can see the hyperthyroidism and thyrotoxicosis. In hyperthyroidism, they increase the thyroid hormone. You can see here, increases in the thyroid hormone biosynthesis. Okay. Thyrotoxicosis, hypermetabolism, not the hyper, but it is the hypermetabolism that results when serum concentration of T3 or T4 both are increased. It is all about the hypermetabolism, and the hyperthyroidism is about the increases in thyroid hormone biosynthesis. The main difference you can see. Now, what are some causes and symptoms caused by disorder that result in increased circulation of thyroid hormone, like toxic diffuse goiter, known as Graves' disease, toxic uninodular or multinodular goiter, painful subacute thyroiditis, silent thyroiditis, toxic adenoma, iodine and iodine-containing drugs, radiographic contrast agents, trophoblastic disease, including hydatidiform mole, exogenous thyroid hormone mutation. You can see some symptoms of hyperthyroidism: nervousness, tremors, mental disturbances, irritability, difficulty sleeping, bulging eyes, and large thyroid goiter, menstrual irregularities, light spirit, frequent bowel movements, warm, moist hands, post-primary miscarriage as well. You can see here some right, hoarseness, deepening of voice, persistent dry or sore throat as well, difficulty swallowing, palpitations, tachycardia, impaired fertility, weight loss or gain, sleep intolerance, increased bleeding, sudden paralysis, family history of thyroid after diabetes. Now, initial evolution of the patient with hyperthyroidism, that is social history, PE, TSH, SE2, SE3, thyroid uptake, thyroid stimulating immunoglobulin, phosphate trace disease, USP of thyroid gland. Graves' disease, toxic diffuse goiter. What is it? The most common cause of the hyperthyroidism it is the Graves' disease, which accounts for the 60 to 90% of cases. Incidence in the United States estimated that 0.02% to 0.4% of the population affects more females than the males. Its main point you can see it's important to suggest that it affects more males than the females. Thyroid stimulating immunoglobulins may be positive in some patients and helpful for the diagnosis. Toxic multinodular goiter is more common in places with lower iodine content. Accounts for less than 5% of thyroid cases in iodine sufficient area. Evolution from the sporadic diffusing goiter to the toxic multinodular goiter is gradual. The thyrotropin receptor mutations and TSH mutations have been found in some patients with CMNG. Surgery or in recommended treatment. What is the thyroiditis? Here some types, some are acute, some are subacute, some are chronic. Thyroiditis acute, it is the bacterial infection from the Staphylococcus, Enterobacter. Fungal infection from the Aspergillus, Candida, Coccidioides, Plasma, and pneumocystis. Radiation thyroiditis after one treatment, the amiodarone as well, and subacute is a viral granulomatous thyroiditis, silent thyroiditis, including the postpartum thyroiditis and myocardial infarction as well. Chronic autoimmunity and focal thyroiditis, Hashimoto's thyroiditis, atrophic thyroiditis, and the regional thyroiditis and the parasitic thyroiditis, traumatic outbreak. Now, decrease is uptake and so in acute thyroiditis. Thyroid may be aggressively tender on exam. Some may have the anti-TPO, AB plus anti-TG, AB, and EHESR. Does not respond to anti-thyroid medication or IRI treatment. You can see here some diagnostic points. So thyroid unexpected, thyroid pain. If it is yes, toxic appearing process. If it is no, then the if it is no, if the patient taking one of the drugs commonly associated with the thyroid dysfunction, amiodarone or the interferon. If it is a yes, then the history of radiation of trauma is yes or no, or the infectious thyroiditis. If it is infection thyroiditis, then yes. If it is history of radiation of trauma, if it is yes, radiation or the trauma reduced the thyroiditis. If it is the no, low thyroid stimulating hormone level, high thyroglobulin level. If it is the yes, subacute thyroiditis. If it is the no, thyroid. You can see here, if it is the no, the measurement of thyroid stimulating hormone level, no. If it is yes, drug-induced thyroiditis. If it is the high postpartum and low postpartum. You can see here, thyroid scan with radioactive iodine uptake. If it is high, that is Graves' disease. If it is low, the silent subacute thyroiditis. If the postpartum is low, with the thyroid can be with radioactive iodine uptake. If it is low, the postpartum thyroiditis is hyperthyroidism. You can see here the postpartum. In the both, you can see the both is high. Okay, it's the both and high. If the high thyroid with radioactive iodine uptake or high iodine with radioactive iodine uptake, both can cause Graves' disease. and the low of thyroid gene can cause hyperthyroidism and thyroiditis. Again, cause the upper state thyroid gene is related to Now you can see here in the next slide about iodine-induced hyperthyroidism. Now starting about some thyroiditis. Thyroiditis is a group of disorders, all cause thyroid. Clinical picture varies from hyperthyroidism. Thyroiditis is divided into three Now, Hashimoto's thyroiditis, subacute thyroiditis, reduced thyroiditis, and pregnancy-induced thyroiditis, palpation-induced thyroiditis, radiation-induced thyroiditis, acute infection thyroiditis, and drug-induced thyroiditis. Now we discuss about the Hashimoto's thyroiditis. You can see here the Hashimoto's very inflamed. Thyroid is very inflamed, large, and hypofunctioning thyroid culture. And it is characterized by the gradual thyroid failure. It is of autoimmune destruction of the thyroid gland. That's why the name Hashimoto's thyroiditis is derived from the 1912 by report by the Hashimoto describing patients with goiter and intense lymphocytic infiltration of the thyroid or stroma lymphomatosa. The most cause of the thyroiditis, it is the Hashimoto's thyroiditis. Okay, this condition is the most common cause of hypothyroidism, the most common cause in the United States in individuals older than 60 years. The form of the thyroid disease may also be referred as the chronic lymphocytic thyroiditis. Its incidence in the disease is of older women, can occur in children, non-endemic goiter. The coincidence rate in monozygotic twins is about 30 to 60%. Oh my goodness, it's very mild, you know. Several chromosomal abnormalities have also been associated with thyroid hypertension. It reports that the polymorphism in the HLA locus, specifically the HLA-DR3, HLA-DR5 alleles are linked to Hashimoto's thyroiditis, but the association is very weak. The genome-wide linkage analysis in families with Hashimoto's have provided evidence for the several susceptibility of loci such as the chromosome 63 and 23. What is the pathogenesis? It is autoimmune disease, immune system. Immune system reacts against a variety of the thyroid diseases. There is progressive depletion of the thyroid epithelium, thyrocytes, which are gradually replaced by the mononuclear. And what is the morphology of the Hashimoto's? The thyroid is often diffusely enlarged. The capsule is intact. Gland is well demarcated from adjacent structures. The cut surface is pale yellow. What are the clinical features? Fatigue, drowsiness, difficulty with learning, dry brittle hair, nails, dry itchy skin, puffy face, constipation, weight gain, heavy menstrual flow as well. These are some clinical findings of the Hashimoto's. Differential diagnosis is being used for active syndrome, goiter, diffuse toxic goiter, lithium-induced goiter, non-toxic goiter, toxic nodular goiter, hypopituitarism, pan-hypopituitarism, polyglandular autoimmune syndrome. Now, special investigations of this Hashimoto's, it is thyroid antibodies, anti-TP or anti-TG, FNAC and TSH as well. and diffuse lymphocytic plasma cell infiltration with formation of the lymphoid follicles from the follicular hyperplasia. The damage to the follicle affects the membrane. And another is subacute thyroiditis, the cell-limited thyroiditis associated with the type-A clinical course of the hyperthyroidism, and return to the normal thyroid function. It is responsible for 15 to 20% of patients presenting with thyroiditis. Now you can see in general the following three forms of subacute thyroiditis are recognized: subacute granulomatous, subacute painful or deep curved thyroiditis, lymphocytic thyroiditis, also known as the subacute painless thyroiditis, subacute postpartum thyroiditis. The curved thyroiditis self-limited disease is caused possible viral cause. Clinical pictures are the first 1 to 4 months. This phase can be characterized by the slight enlargement of the thyroid, anxiety, restlessness, insomnia, weight loss, acute hemorrhage into the thyroid nodule, weight loss, infections, thyroiditis, radiation-induced thyroiditis, trauma or salvation-induced thyroiditis, radial or thyroid thyroiditis, grave thyroiditis, toxic thyroid melanoma. Blood tests to measure the increased levels of thyroid hormones in the blood stream. The diagnostic point of the subacute thyroiditis and abnormal antibodies, antimicrosomal, anti-thyroglobulin antibodies. A fine needle aspiration you can see is the biopsy of the thyroid gland. During this phase would reveal these inflammatory cells attacking the thyroid gland. Treatment is the hyperthyroid phase. Treatment is usually not recommended because of this phase usually lasts for a short period of time, about 2 to 4 months. However, if symptoms are extreme, the beta blockers can be used to slow the heart rate and lead to nervous flow. Thyroid hormone medication for about 6 months. After this time, the medication is stopped to determine whether or not the thyroid has recovered normal function. If so, the medication may be stopped permanently, otherwise the medication must be resumed because of the permanent injury to the thyroid gland. Radial thyroiditis. This is a rare disease. It is replacement of the normal thyroid parenchyma by the dense fibrosis. Painless, whiter, woody, open biopsy often needed to be diagnosed, associated with the vocal syndrome. Clinical features about non-painful, rapidly growing thyroid mass. This is the diagnosis on the basis of decoable thyroiditis, whiter Hashimoto's thyroid, and a plastic carcinoma thyroiditis. Complications, lot of complications you can see as area of obstruction, dysphonia, hoarseness, hypothyroidism, hypoparathyroidism. Treatment is about the corticosteroids, tamoxifen, and levothyroxine. Surgery is the weight reduction of thyroid. Surgery is indicated when tissue is needed. For diagnosis, medical treatment shows no benefit or symptoms are just severe. Drug-induced thyroiditis drugs include the amiodarone, lithium, interferon, cytokines. Some clinical features are either thyroiditis or hypothyroidism. Radiation-induced thyroiditis, you can see various providing for the hypothyroidism, adrenal dropping for thyroid. The clinical features are occasionally thyroiditis, more frequently hypothyroidism. Acute infections of thyroiditis. Acute thyroiditis is quite rare in modern times, mostly caused by the bacterial infection in the thyroid, which causes pus to collect and form an abscess within the thyroid gland. The bacterial infection may be carried in the bloodstream from anywhere in the body. You can see the thyroid toxicosis is transient and hypothyroidism is usually permanent. You can't be treatable from the hypothyroidism. Treatment of the thyroiditis. Treatment depends upon type of thyroiditis. namely thyrotoxic causes hyperthyroidism and thyroid. Thyrotoxic causes the beta blockers to reduce the palpitation and reduce the shakes and tremors by the health process. In hyperthyroidism, thyroid hormone replacement is occurred. In thyroidal pain, anti-inflammatory medication we can use like aspirin, steroid therapy with prednisone and corticosteroids. These are some all about the thyroid hormone. Now discuss about the Graves' disease. The Graves' disease is also known as the toxic diffuse goiter. It is an autoimmune disease that affects the thyroid. The Graves' disease is a type of autoimmune problem causes thyroid gland to produce too much thyroid hormone. The common cause of the hyperthyroidism often results in large thyroid. The Graves' disease will develop about 0.5% of the males and 3% of the females. It occurs about 7 times more often in women than men. The exact cause is unclear. The Graves' disease will develop in about 0.5% of the males and 3% of females. It occurs about 7.5 times more often in women than men. The exact cause is unclear, but however it is believed that it involves a combination of genetic and environmental factors. These are some genetical factors that seen with some people more prone to develop. These as such receptor in activating antibodies due to genetic cause. Infectious trigger it is said which appears suddenly, often later in life, viral or the bacterial infection. To trigger antibodies cross-react with the hormone TSH receptor. A phenomena is known as the antigenic mimicry. Now it is autoimmune disease that triggers the protection of the antibodies. These antibodies have the special similarity to the thyroid stimulating hormone. Thus, this antibody will bind to thyroid stimulating hormone receptor instead of the thyroid stimulating hormone. The binding of this antibody leads to activation of this receptor. Once this receptor is activated, there is the excess production of the hormone T3 and T4. Thus, in turn, the causes of the clinical symptoms of the hyperthyroidism and the enlargement of the thyroid gland visible in the goiter. You can see here, this is the thyroid. This is the thyroid receptor, where the thyroid stimulating hormone acts on the TSH receptor. It stimulates the hormone synthesis to produce the production of thyroid hormone. High amount of thyroid hormone can have negative feedback to the pituitary gland to decrease the amount of TSH. Okay, they can decrease the amount of TSH if they are in high amount. If they are in high amount, they can decrease the negative feedback, or we can say decrease the amount of TSH. But you can see here, autoantibody receptor instead of the TSH, these autoantibody receptor antibodies can attach to the receptor, TSH receptor. They stimulate the hormone synthesis. That we can see a lot of hormones, but they have no way to decrease the amount of TSH because there is the TSH not is attached, but the autoantibody receptor is attached. That's why the high amount of the hormone can cause the goiter, and it means they have a large amount of the unregulated overproduction of the thyroid hormone. Now, autoantibodies to the TSH receptor. Three types of autoantibodies to the TSH receptor. Currently recognized as thyroid stimulating immunoglobulin, thyroid growth immunoglobulin, thyrotropin binding inhibiting immunoglobulin. These are some symptoms: exophthalmos, goiter, insomnia, hand tremor, hair loss, excessive sweating, itching, heat intolerance, weight loss despite increased appetite, diarrhea, frequent defecation. Here the goiter, exophthalmos. You can see increases the exophthalmos because the eyeball is forwarded. In goiter, you can see here the large swelling of thyroid gland because the overproduction of thyroid hormone. Diagnosis by the physical exam, blood test, TSH level, and iodine uptake. If the high amount of TSH level, it means high amount of TSH level in the body, then it may cause that the high level of the TSH can binding to the antibodies. Okay, the low level of TSH, the high level of thyroid hormone, and the MRI and CT scanning, and iodine uptake test as well. Treatment is radioactive iodine therapy, anti-thyroid medication, beta blockers, surgery. We have some talking about some pathogenesis of the hyperthyroidism. You can see here stimulating TSH receptor antibodies and toxic adenoma and multinodular goiter, okay, and acute thyroiditis due to some viral infection. The stimulating increasing stimulation TSH receptor antibodies have been called the Graves' disease. We have studied about the Graves' disease. Then this H production independent of the TSH and damage to the thyroid follicular cells. You can see here acute thyroiditis. These three you can see here. These three can cause the primary hyperthyroidism. The primary hyperthyroidism we can see here in the left side because we know what and this makes increase the iodine uptake and persistent decrease of TSH and increase T3 and the T4. It means increasing amount of T3, T4 and decreasing TSH by the negative feedback by the increasing amount of the T3 and T4 as well. And after that, in second, you can see here the local synthesis of the glycosaminoglycan. So, to increase the local synthesis of the glycosaminoglycan, that increase the osmotic pressure behind the eyes, which may cause the eye symptoms. These are disruptosis, diplopia, lid retraction, and the conjunctivitis. And increase the local synthesis of the glycosaminoglycan. You can see here increase the hyaluronic acid in dermis and sub. You can see here and the subcutaneous. They increase the peritibial magnesia. After that, you can see here in the increase the sympathetic stimulation as well, which increase the sweeting. If you go downward, that may have increased the RAS activation and increase the erythropoietin synthesis, that increase the cardiac output as well, which increase the symptoms of the cardiac, known as there is some tachycardia, palpitation, bleed over thyroid, and increase the exercise tolerance. And you can see here the increase the thermogenesis as well, which increase the weight loss, heat tolerance, and increase the appetite. Okay. And another you can see here the release of the stored TH hormone. So decrease the uptake and transient decrease TSH, increase the amount of the and sympathetic stimulation and by the CNS and blood hypermotility, which may cause diarrhea, increase bowel movement as well. And CNS overstimulation which cause the nervousness, you can see here the hyperkinesia, hyperplexia, tremors, and poor attention. Here is some about the Graves' disease. B and T lymphocytes mediated autoimmunity attacks TSH receptor. They have continuous stimulation of the thyrotropin receptor by the circulating autoantibodies. You can see here. Okay. Then they have increased the sodium transporter, increased the sodium iodine transporter, increased the iodine uptake and intracellular iodine. You can see here. Okay. And increase the thyroglobulin synthesis and upregulation of the CNP and PKC pathway, increasing the seed synthesis, secretion, and cell proliferation. Now you can see here the continuous stimulation of thyrotropin receptor by circulating autoantibodies. They have three important. One, you see, increase the sodium iodide transporter and increasing the iodine uptake and intracellular iodine. It means the iodine is in full and the increasing amount of iodine into the sodium iodide transporter and increasing in the thyroglobulin synthesis as well, because the continuous stimulation of the thyrotropin receptor by circulating antibodies and upregulation of CNP as well, because they have increasing seed synthesis as well and secretion and the cell proliferation. Now we have the increasing the thyroglobulin synthesis and increasing amount of iodine, which may increase the iodination of the thyroglobulin as well. You can see here thyroglobulin. You have this is thyroglobulin, increasing amount of thyroglobulin, and there is the thyroid gland hyperplasia. Now these are symptoms which may cause the Graves' disease. Increasing amount of iodination of thyroglobulin, okay, this may cause the Graves' disease. The Graves' disease has increased TSH and stimulation, which may cause the goiter. In Graves' disease, which is the main symptom of the hyperthyroidism, which may cause hyperthyroidism. Hyperthyroidism, which may be inflammatory response initiated by the activated T cells, which cytokines increase the glycosamine and glycogen secretion by the fibroblasts, increase the immune complex deposition in the dermis and the immune complex deposition in the eye. We have studied in previous lesson about the hyperthyroidism. And with the goiter, you can see the compressive effect and increase the blood flow. Increased blood flow may cause the thyroid gland breach and the hoarseness dysphagia by the compressive effect, which is goiter. Now see about the Hashimoto's thyroidism. You can see things are there, molecular mimicry and genetic specificity and confront autoimmunity. You can see here the molecular autoimmunity develops against the pathogenic entities that resemble the human protein. And patients with born, you can see here the genetic patients born with immunological receptors capable of recognizing self-thyroid antigens. And the autoimmune conditions like the Graves' disease, DM1 celiac disease, these may all three cause the lymphocyte T and B cells seek the self-thyroid antigens. These self-thyroid antigens then the lymphocytes infiltrate the thyroid gland. Then the T cells are activated. You can see here, T cells are the activated here. Then the T cell mediated destruction of the thyroid gland to decrease the production and secretion of T4 and T3 from the thyroid gland. And you can see here the lymphocytes infiltrate thyroid gland, then increase these cells are activated to increase the production of anti-thyroid antibodies, which may be detectable anti-thyroid antibodies, anti-thyroglobulin and anti-thyroid peroxidase antibodies. You can see here in the T cell mediated destruction of the thyroid gland, there is inflammation and the loss of the normal thyroid gland and architecture. If it is the stress and the thyroid gland significantly destroyed, it will be present as a trophic, small, firm and degenerated. if thyroid gland is significantly inflamed and fibrotic, it will be present as goiter, large and lobular in character. If it is decrease the production and secretion of T4 and T3 from the thyroid gland, you can see here the variety of the mechanisms we have general symptom of the hyperthyroidism and the decrease negative feedback loop inhibition of the pituitary gland with an increased amount of pH.